Perfect.
Tom, are you ready?
Yes, sorry, I will do my best to catch up.
No, don't worry.
I can see one face. I'm new to Starleaf and new to the hospital, so I can see one face on my screen, but there might be more people listening, I'm not sure. So my name's Tom Hardy. I'm a locum consultant paediatric anaesthetist, not from the region. I trained in London, and I've been here for not that long, as you can probably tell by my ineptitude at setting up Starleaf. I will try my best to catch up. So I know Samira Ahmed, one of the other consultants, talked about physiological effects of anaesthesia last week and the gas trial and the various bits of evidence that surround that. So I thought it was reasonable to follow on by one of my kind of subspecialty interests, which is perioperative anxiety. So I did my fellowship at Great Ormond Street, which was led by a couple of the people who started the POEMS course, and that's where it really started. And I've kind of helped out with them and put in a few initiatives at other places, which I may try and bring to here now that I'm started. So do I click to press through? Or how
you just press left and right, or up and down.
Up and down.
Okay.
So I was quickly just going to give you a summary about what actually is perioperative anxiety. Why having an anaesthetic causes anxiety. I think probably most people can know what those kind of things are anyway. But what the evidence says the potential consequences of it are, and more importantly, what can we do about it? What's in place in this trust, and maybe a vision for the future about what we could do. So most importantly, I don't know if there's any anaesthetists listening or whether I'm the only one talking, but anxiety doesn't feature in the whole 100-page document of our curriculum, and I know that partly because I've not long since I finished training, but also because I looked up and read it. It appears 6 times, all in the optional module of dentistry, and none of it relates to the fear of anxiety of anaesthetics. It all relates to the fear and anxiety of dentistry. And actually, kind of the anaesthetic management of malaria appears more than anxiety, and also so does kind of drugs we don't use anymore, such as ether and halothane. So it looks as if it hasn't been at the forethought of our minds for a little while, certainly in curriculum design. But the new curriculum, which is even withstanding COVID, will come out in 2021. Shows that it's really starting to take hold as a theme, and it appears throughout, and certainly within the kind of higher and advanced modules of anaesthesia for paediatrics, we are now kind of tasked with these statements about being able to provide perioperative care, including the anxiety management of children, and we should be efficient in the techniques used to reduce anxiety of all ages. So what actually is it? This is my daughter. She's 3. At this time when this photograph was taken, she was using a pair of kitchen scissors to try and cut my newborn baby's hair. And I was quite happy to say that the right thing to do was to intervene. I was happy that I was putting all parties' best interests at heart. And it highlights that some people, the view that some people take, you can't always get what you want. Part of growing up is being told that you have to do things that you might not necessarily want to do. And actually, if it's in your best interest, like having an operation or an anaesthetic, it doesn't really matter. You just need to get on with it. I suppose that is one train of thought, but that relies on the fact that you assume that the anaesthetic event is in the best interest of the child. Now, as an anaesthetist, quite often we'll get a name on a piece of paper that's next to an operation, and we make a lot of the assumptions that that decision has been made already, that the conversations with the relevant people, often multidisciplinary ones with paediatricians, surgeons, parents, counsellors, have all been done. And we as the anaesthetists often are seen as the service providers at the end who have to kind of negotiate this anxious child, making the assumption that this is the right thing to do. That's the coronavirus. It's in there because we can't have a presentation without coronavirus. So what actually is perioperative anxiety? So the first proper description in a peer-reviewed journal appeared in the early 1970s, where it described it as an unpleasant state of uneasiness or tension. And it was really, the definition was around the kind of the psychological component. It wasn't related to any physical manifestations. It was really describing this kind of anxious state that children get into and what they could maybe do to manage that. And if you fast forward 25 years, which is still 25 years ago, then we kind of start to get this concept that this perioperative psychological anxiety really does have potential physical manifestations with catecholamine surges, exaggerated stress response, and involvement of the autonomic nervous system. And then I think from there, people really start to take a bit more interest in the fact that actually we can improve perioperative outcomes maybe by managing anxiety a little bit better. certainly for kind of children who tend to present frequently. And what we know from the evidence that exists is that the induction, the whole perioperative journey, is the induction of anaesthesia that is most likely going to be the most stressful experience for the child. And we know that up to 3/4 of children have moderate to severe anxiety in the anaesthetic room. And it's not really hard to see why. There's this kind of crescendo event that's building towards something the child potentially know about is going to happen, that they don't fully understand, that there's nothing they can seemingly do to get out of the way of it. And when I've spent kind of the last 15 years in training and the last 5 years really doing a lot of paediatric work, and I feel I've kind of developed my pattern and my communication to a point where I feel quite comfortable that I can get the information across to the parents without necessarily terrifying the child in a closed cubicle on a busy ward, trying to kind of understand and take cues from the child as to how I think the situation is going to go. And when I did this presentation to some anaesthetists who beginning of their journey, I kind of wrote down what I would say if I was maybe being really blunt and brutally honest. And it goes a bit like this. Hi, I'm a stranger and I'm going to make you go to sleep. We'll take you to a strange room with funny smells and machines, and I'm going to hold a mask over your face and maybe put a needle in you. My team will hold you down until you fall asleep. Then your mummy and daddy will leave you with us, and some other friends of mine are going to do something to you that you don't understand while you're asleep. We're then going to wake you up, and there'll be more strangers, and you might have pain, feel sick, and be confused. Don't worry, though. I do this all the time, and there's only a small chance that something really bad might happen. Oh, and also, you can't eat or drink, so you're going to be hungry for a little while. It's terrifying when you break it down like that. And I think we have to accept the fact that all children will have a degree of anxiety, even those ones who don't kind of outwardly manifest it. What we know from the papers, the big peer-reviewed papers that exist, is that there are some things we can do to try and predict risk. But doing a good literature search on this subject, you can almost prove any point that you want by quoting some kind of paper with regard to this subject, that pre-meds are good or bad, that parental presence is good or bad, that age does or doesn't take an effect, that the temperament of the child does or doesn't. But the big papers that have been extensively peer-reviewed and the meta-analysis of the events generally show a trend towards the age ranges where we're likely to encounter certain issues, how the temperament of the child, both descriptive from parents and also descriptive from the anaesthetist, play a part, what a significant role outward emotion and parental anxiety shows, and how previous hospital experiences can have quite a significant effect as well. And what we know is that all of that goes together to create this bubble of perioperative anxiety. And then we are left as anaesthetists with kind of to work out how we can best overcome and manage that. Now, we've got on one string, on one arm, pharmacological interventions, which will be most commonly known as the pre-medication, of which there is an expanding range, and there's reasons why they're expanding, which I'll come to in a little while. But also behavioural interactions and interventions, and certainly hospital policies and interactions that we can put in place. Most notably things like parental presence, changing the environment, and the role of new techniques and new technologies such as distracted methods with iPads and such. It all comes into play, and not one method will work for every child, as I'm sure we're all aware. And what we're aiming is to modify this outcome so that there's a minimal psychological effect, and in turn with that we can reduce any clinical manifestations of perioperative anxiety. So a bit about the kind of better or bigger papers that exist on this. So we know that between 20 and 60% of children will develop some kind of dysfunctional behaviour if they have a hyper-anxious induction within 3 weeks following surgery. And we know there's evidence that this may last up to a year. And these are bracketed to a whole range of issues, but notably eating disorders, problems with sleeping, bedwetting, or problems with authority. And it's difficult because I know my 3-year-old probably suffers with quite a few of those, and she has never had any kind of hospital encounters. We also know that an acute physiological stress, psychological stress, such as a significant anxiety episode, is associated with an increased stress response and stress hormone release. And we know that the contribution, thinking about this, that we can't ignore this really any further. And this statement came from a paper that was published in the mid-90s, and it kind of led on to a number of other studies and investigations that have taken place. And we know also that stress response, once it becomes a physical manifestation involving neuroendocrine loops, we get a glucocorticoid surge. We are putting potentially children at an increased risk of wound infections and altered immune function. And I think neoplastic disease probably goes a bit too far, but actually when you study this in animals, then it certainly is the case. We also know that children are particularly vulnerable to the surgical stress response because of a number of reasons: larger brain masses, high glucose requirements, and their relatively small energy reserves. And we know that the neuroendocrine hormones that circulate do delay wound healing and potentially cause immunosuppression, as I mentioned before. So when you think about all these things, when you make a list of the potential consequences of pre-operative anxiety, it is quite significant. If we think about in the short term, certainly I see it on a daily basis. If you see a child who goes to sleep with a big catecholamine surge, very anxious and upset, they tend to be very similar in recovery. We tend to find that they have more pain, and that certainly is evidence-based. These children do have higher pain requirements initially in the recovery room, but also for 24 to 72 hours post-op. We know that means they need more opiates. We know that increases perioperative nausea and vomiting, and we know it increases recovery time. So what do we do about it? As I alluded to before, everyone is different. This is not a straightforward condition. It's a complex interaction of prior experiences, home environment, age, development. And to say that I have a magic recipe that's going to fix this is certainly not true. We all know that I won't be condescending and talk to you about how to talk to a child, because a lot of people on the call, I'm sure, have done this for a lot longer than I have. But it's just strange that certainly to anaesthetists, none of this is really taught. No one sits down to you and on your first time you're doing paediatric lessons and says, "Have you ever thought about how you are interacting with a child and making them scared and how you do it?" And certainly I know about this because I've worked at places that do take this very seriously, and it's been my career choice. But it's certainly not something that's been in place for anaesthetists before the 2021 curriculum. And what we know from all the evidence that does exist is that there certainly seems to be 5 significant fears that develop in childhood regarding perioperative anxiety, and they increase with increasing age. And the first one that seems to appear is separation anxiety from parents, and then it becomes an environmental fear before the fear of something painful happening, and then actually the cognitive understanding of what's happening to oneself, the operation, and how it will help you, before actually the final fear of anesthesia, where it's associated with loss of control, which is sometimes the fear that parents put on us. That they're losing control of the care of their child to a stranger. But as children grow, these fears tend to develop in that kind of direction, and the final 3 really do persist into adulthood, as I'm sure a lot of people who maybe have had operations or anaesthetics might expect. And certainly myself, having an operation as an adult and as an anaesthetist, my fear of losing control and seeing the registrar conduct my anaesthetics filled me with terrible fear. So what else? What evidence-based programs are in place to make this better? So the first and most significant one is the psychological preparation programs. This hospital has psychologists who are involved with certain aspects of perioperative care, particularly for set subgroups of children, for example, transplant patients over at the Freeman, cleft lip services and cleft palate services. But we don't have a dedicated, as far as I'm aware, and I'm new here, as far as I'm aware, we don't have a dedicated psychological services that we refer specific children to who are deemed high risk of perioperative anxiety. But the studies that are out there do show that such programs do work. They enhance coping strategies in children, and that's of all ages. But most of the research work comes out of the United States. I worked at Great Ormond Street, who had a very established program for this, but it was really built around their transplant program rather than being for children off routine anaesthetic lists. But the way that one worked was that they would transfer their skills across and happily accept children undergoing any operation. But whether we would fulfill a job role for such a person or such a process, I'm unclear. There was a really nice study that looked at this in detail that was published in Pediatric Anesthesia in the late 90s, and it cohorted children into 3 different levels of perioperative anxiety management based on degrees of information, modelling programs and video tours of operating theatres. And it actually found, although there was a general tendency to improve anxiety at all stages of their journey, it was only actually statistically significant in the immediate bit before entering theatre. And once you actually got through the doors into the anaesthetic room, it made no difference to the induction of anaesthesia at all. And it made no difference in any of the statistical difference in any of the post-op care. Everything's referenced if anyone wants to look things up. It's all come at the reference slides at the end. What else can we do that's kind of is readily available to us? And how it would come as no surprise to most people, I'd imagine, that parents and children both want to be together at the induction of anaesthesia. But again, this is one of those bits where you can really find what evidence you want to say, and it's very mixed to say how much and how significantly this helps. One bit of relatively conclusive evidence is that when predicting how a child will react going off to sleep, fathers do tend to be better at it, or more accurate at it, should I say, than mothers. And what the papers that kind of show this show that the paternal kind of relationship seems to be more factual rather than emotional. And again, this isn't my opinion. This is just the opinion of some work that I think was done quite nicely. Again, have I found that subjectively? Probably not. I do tend to find that mums get more upset in the anaesthetic room, which transcends anxiety to the child, and certainly that's what also the general literature seems to show too. What we do also know is PPIA, parental presence induction of anaesthesia, is not as good as having a pre-medication at obliterating anxiety for the child. And actually, once you add a pre-medication to the parents being there at the same time, that makes very little difference. So parents on their own with no pre-med is not as good. Pre-med's better. Parents and pre-med is just the same. But what we do find is that those children who are pre-medded and parents come with them, that there is generally improved parental anxiety and satisfaction with regard to the whole event. And I can understand that because a well pre-medded child thinks the whole thing is quite nice and peaceful, and it probably transfers across to the parents too. And so pre-medication, when I first started, I thought it was this golden bullet that would get you out of all holes, and you could go and squirt things up children's noses or give them a drink and everything, your life would be happy. But it doesn't always work like that, and there's some significant reasons why it doesn't work like that. The first one is that it's not the nicest thing to have. Midazolam tastes horrible. Dexmedetomidine up the nose isn't that comfortable or great. And actually, children spit things out that they don't like. And actually, you can potentially, by administering something that's not fully ingested or doesn't work properly, the sheer action of giving it to the child can actually make the situation more heightened and worsened. We have to face timing and planning issues with regard to a whole theatre list, and certainly I've been in a situation where we've had multiple pre-medications, which have meant the last child on the list has then sat hungry or starving or getting more upset, and the last child ends up being the most difficult one to manage, and you've had these three lovely kind of pre-medicated anaesthetics beforehand, or even worse, potentially cancelled if you run out of time. And the final thing to say is that there's a lot of evidence to say that once you hit between 6 and 7 years of age, most children want to know more about what's happening, particularly related to pain. And once you are honest about pain control, all the evidence that the pain that's likely to occur and what you're going to do about it, a lot of anxiety seems to settle. And I've certainly been in situations where a child is hyper anxious on ward 8 before coming round, and actually all they wanted was to ask about one specific thing. And once they had that question, they were still a little bit teary, but they were much easier to manage. And pre-medding and taking a child out of the here and now and making them kind of completely unlucid for the event is not necessarily in the best interest of going forward, particularly with children who are likely to appear again and again. But it certainly does have its place, and there's potentially a lot of room a lot of work we can do to kind of make our range and administrative routes better for pre-medication. So how do I think we move this forward? Firstly, I think we're a lot better at it than we were certainly when I started. It seems to be 10 years ago relatively acceptable to excuse the terminology, but hold a child down and put a mask on, and that was a well-recognised way of anaesthetising a child, and that's only 10 years ago. And certainly when I was at Great Ormond Street, there was a serial audit of how many children you had to restrain with a mask to conduct anaesthesia. And over the past 20 years, it's gone down from something, I think it was in the high 70% range, down to less than 10%. And I get it, it's a hospital with lots of money and resources and facilities, but I think the concept is sound. And by training anaesthetists who come through to identify this this kind of quite significant issue better, I think we'll make headroads. I think the proposal of these approved pre-operative anxiety management courses, such as POEMS, which some people may have been on. I know they run a course up here in the Northeast, or have done in the past. To more novel techniques such as hypnosis, which is really, really good evidence for. I've seen it work firsthand in the anaesthetic room, and I was blown away. I thought it was all nonsense, and then having seen it quite a few times by the clinical hypnotherapists at Great Ormond Street, it really is quite remarkable. And one thing on a kind of more fundamental and simple level is improving access to what we've done before. It's not uncommon that you meet parents and they say, oh, just hold him down, that's what they've always had to do. And actually, if we can write clearly what we did and it works well, then that's great. But also if we can write clearly what we did and it didn't work well, and make recommendations for the future, then I think that's really just as valuable. And I take it as a personal challenge to see, when I meet a parent who says, oh, it was really difficult the last time, everyone got upset, it's a personal challenge to me to say, what can I do this time that's better than the last time? And I think if we all kind of thought like that, as I think a lot of people in tertiary centres do, because we see kids all the time coming back and back and over and over again, then I think that's a very worthwhile attitude to take. And then certainly that fits with the evidence that exists to say in district generals, where your pre-operative anxiety appears to be much more prominent in district general hospitals than tertiary centres who have dedicated paediatric anaesthetists and paediatric nurses. And the final thing is better pre-medication options. There's a lot of work going into a transdermal sufentanil patch, which is, I believe, in the kind of trial stages at the moment, which would be a simple sticker that you can put on 20 to 30 minutes before an operation, from some of the evidence that I've seen, and then creates sedative and anxiolytic effects that are similar to an oral midazolam, which I think would be really nice. And there may well be more things that come forward. We've only had dexmedetomidine for a little while, and that's been kind of quite helpful in the drug-resistant anxiety where you've already given midazolam and it hasn't worked. So there's some educational plans for the future. There's some novel therapies, and there's also kind of scientific invention, for lack of a better word, and pharmacological intervention that we may improve things as well. The main thing that I kind of just want to end on, because I know that I'm going on quite a long time, is if we have on our scales, mental scales of the clinical need for the anaesthetic now versus the potential psychological consequences of having an anaesthetic now, occasionally there's no choice. You just have to crack on. But there is quite often the option of cancelling or of pausing at the time, putting a child to an end of a list, seeing what else we can do, or even cancelling and referring to a friend, the psychological services that do exist, and bringing them back at a later date, particularly if it's non-urgent. And just on that note, I came up from London, as I said before, and we cancelled all our elective work at the hospital I was in during the coronavirus pandemic. And there were 18 either children or adolescents who were booked for either tonsils or adenoids or a combination of both, who ended up having a phone consultation instead of their surgical appointment. So these are children who were booked. They had an operation date. They were supposed to come in fasted. They had a consultation. 18 children were taken off the surgical list. Now, whether they stay off forever, I don't know. Whether they, in 6 months' time, they're back on the list having an operation. But it was deemed during the phone conversation that they would either have another face-to-face clinic within 6 or 12 months, or they were off the list altogether based on resolution of symptoms. Now, some of those children may well have arrived on the day, and it may well have been assessed that they didn't need to have an anaesthetic, but they would have still come into the hospital environment unnecessarily. And this is purely just, it's come about because of COVID, that maybe we do anaesthetise some children who don't need it. Maybe it's not always in the best interest. And again, I don't know what we can do about that. We've got an established system of seeing children, booking them for theatre, and making a plan. It was just, we can't take many benefits from COVID, but we can ask some questions as a result of it happening, and maybe that's one of them, that may potentially up to 18 children had avoided an anaesthetic that they didn't need to have. So again, these are the questions I ask myself when I'm seeing someone who I think looks a bit anxious. Does it need to happen now? Is there anything else we can do? Are there any friends who can help me? And this is in my kind of mental note that I have when I'm seeing someone who's quite worried. And the final thing is about breaking the cycle. Children who've had a really rough time before, as I said before, parents who describe terrible occasions, is always thinking, what can we do and what can we do better? We're a tertiary centre who see repeated offenders, for lack of a better word, who come to theatre, 5, 6, 7 times, maybe in a short space of time, and we should be seeing this as an opportunity to do things better and potentially write recommendations and recipes for people who follow on from us. It's a minefield. As I've said, there's no one size fits all, but there's always people to ask and to help, and occasionally you do just have to get on with it and kind of accept that anxiety is something you'll have to manage afterwards. And that kind of relatively rapid run through comes to an end, and I hope it gives you a little bit of a light of the mindset of an anaesthetist.
So if you stop sharing screen, and then
so you show my face.
Yes. So Tom, firstly, that was a fantastic talk, and secondly, it's very nice to have you up in the northeast.
Thank you.
And very good to meet you for the first time, and it sounds like you're going to bring great stuff to our hospital.
Thanks very much. I'm really excited to be here. I'm looking forward to settling in.
So there's some questions from the floor. Frederick.
Tom, thank you very much. So I think there was one slide where you showed that kind of educational help beforehand doesn't really seem to help with the kind of anesthesia induction or 2 weeks thereafter, I think, with videos and walking around and all sorts of things. So I guess that's disappointing. But I guess looking at the people that are phoning in today, most of us are probably not anaesthetists, and maybe most of us are not regularly in theatres. If there were to be one take-home message for us non-theatre-based clinicians, but we all see children that need to undergo surgical procedures, how can we help you?
So I think the thing it's a really useful question, and I think the thing is, I'm almost certainly speaking to people who spend a lot of time with children in healthcare. So like I said, I don't want to be condescending and say this is how you pick up an anxious child, because I don't get it right all the time. But we're probably all at one stage or another involved in booking children for things that need anaesthetics, whether that's an MRI scan, whether that's a surgical intervention. And I would suspect that if there is a suspicion from the doctor or nurse caring for that child, that on the ward or in a clinic or when they're seen, that they will be a potentially difficult child to manage from an anxiety perspective, then highlighting that to the pre-operative anaesthetic team is really useful. Now, I understand that also probably involves a feedback loop, because you don't know which ones you see which are bad, and that's something I introduced at another trust, was saying this child was booked for this. Was there any evidence when you saw them that they might be very difficult to manage? Because when we saw them, they were hyper anxious and there was an issue. And we audited that, and we looked at how we could establish that feedback loop a little bit better. And actually it showed that pretty much, certainly in the hospital I was in, that if clinicians in clinics or on the ward felt that the child might be quite difficult to manage, generally they were right. It's not an anaesthetic skill. So thereby we have set up a pathway where it was on the booking form for theatre that, do I think as a referring specialist think this child might be at risk of significant anxiety with regard to going to sleep. And then one of us would try, and it didn't work as with any new service, it doesn't work seamlessly from the start, but what it meant was that we would, rather than sending the person who's first day on anaesthetics CT1 down to go and pre-op this kind of otherwise ASA1 child, you might send someone a bit more senior who knows a bit more about it maybe along and try and put some methods in place.
Yeah. Okay, that sounds great.
Any other questions from the floor? Oh, can I ask a question?
Yes,
how useful would play therapist be to the anaesthetic team?
Play therapists are really useful, and there was one thing, now you've highlighted it, I've realised I didn't do a slide on play therapists, because all the evidence says that play therapists help reduce anxiety in the pre-op setting, but not once you come to theatre.
Yeah.
The only thing really that kind of is an established reduces anxiety in a hyper-anxious child when they come through the theatre doors is a pre-med. There are things you can do to distraction and help distract, and that's certainly where play therapists are fantastically helpful. And the distraction from anxiety is subtly different from the inner-built fear and anxiety that's there. So I rely heavily on play therapists, and if I've got a child who I see on the ward who looks very anxious, the first person I'll probably go to is the play therapist to say, how can you help me? Is there anything you can do? Having spent time with a child, what things do they like or don't like? Have they given you more clues that can help me make the journey smoother than anyone else?
So that's something which we do have.
Yeah. No, absolutely, yes.
And maybe we can work with you to see how we can best utilise them. Excellent. Anything else on the floor, Frederick?
No, I don't think so. I just again, just like Samir's talk last week, I think it's nice to kind of hear kind of a relatively new topic, and I think it clearly if you've got an interest in it and you can help improve our services, I think that'd be fantastic. Yeah, absolutely.
I think in reality, it's quite a lot of children are anxious coming to theatre. It's the hyper-anxious ones who don't make it through the doors of the hospital in the morning, and there's not many of them, in truth. And there's and actually whether setting up a whole service for this kind of handful of children every year that need this is probably quite a difficult thing to justify, and certainly that's what a lot of the evidence shows. But maybe we can make a pathway that's slightly better than what we already have, and maybe that's going to be my aim and my interest.
Fantastic.
Excellent. Right. Well, I think we'll call it a day then.
I'm sorry I'm late, everybody.
No, not at all. You're new, so that's absolutely fine. So thank you.
Before you close off, Yincent, can I just say that we will have another lecture next Wednesday the same time, and the case will be presented by psychiatry.
Excellent. That would be very good.